Hello everyone, welcome to the respiratory lecture. Before we get into respiratory topics, I have a couple review slides on the previous couple of topics we've done this module with a few questions. Okay, so question number one, this is a review of immunotherapy. We have a 56-year-old male who has chronic heart failure, was recently given induction therapy and received a heart transplant. He is recovering from surgery and it is time to start a maintenance regimen in order to prevent rejection. Which of the following combinations is most appropriate? I've given you a series of choices here, and really the idea is to make sure that you guys can pick a regimen that one, makes sense, and two, doesn't have some sort of a duplicate mechanism of action. And so to be successful at a question like this, the real thing to know is to be able to categorize your drugs into the different classes. Remember, our core immunotherapy regimen, really for any solid organ transplant, I know I focused on kidney transplant, but for heart transplant, it's the same thing. And really, any solid organ transplant is going to have the same core regimen, and it's going to be a steroid. So I gave you that in all the choices, which is prednisone. Then you're going to want either, you're going to want both a calcineurin inhibitor and an antimetabolite. Out of these four choices, the only one that meets that criteria is choice B. So you have your antimetabolite here, mycophenolate, and your calcineurin inhibitor here, cyclosporin. The other ones, so azathioprine is an antimetabolite. Sirolimus is an mTOR inhibitor, which, if you remember from the lecture, is an alternate to either the calcineurin inhibitor or the antimetabolite, depending on toxicity. So that's not one we start people off on, generally speaking. Choice C. Remember, I said I wouldn't really ask you questions about the MAB drugs, and I'm not going to, but if you see a MAB drug on a test question, that probably means it's wrong, especially when it comes to maintenance therapy. MAB drugs really are only used for induction therapy or for severe rejection, and so we aren't going to be using our biologic big gun immune system suppressant agents for anything outside of those windows. So people aren't going to be taking that chronically. And then choice D has cyclosporin and tacrolimus, which those are both calcineurin inhibitors. So that would be a duplicate therapy, and you wouldn't use those two mechanisms together. For this case, I've given you a 67-year-old female who presents to clinic for her annual physical. She feels well, but has been experiencing restricted field of vision. Based on her reported symptoms and physical exam, you decide that she probably has mild glaucoma. You want to have her work up with an ophthalmologist, but you're comfortable prescribing something today. She's on the following medications. I gave you a number of medications. A lot of these we haven't talked about yet, but I did give you the indications. So the big ones to look at would be things involving blood pressure or heart rate. And metoprolol, if you recognize the OLOL prefix here, or suffix, excuse me, that's going to be similar across all beta blockers. So timolol is also a beta blocker, which is the eye drop we might use, and that would be kind of an indicator there to recognize that name and also what it's used for, of course. So if we're going to start something today, what would be the best agent to start this patient on? So generally speaking, unless I give you something specifically that the patient wouldn't do well on a prostaglandin, you're going to always pick the prostaglandin first. They're the better drug with very few complications. Now, if I told you specifically somebody had blue eyes and they were concerned about color change or something of that nature, certainly you might be concerned about that, and that would lead you down that pathway. But I didn't tell you anything about her eye colors. If I don't do that, you can assume safely that the prostaglandin is going to be the drug of choice. Again, really want to stress this. It's not necessarily that you can't use a beta blocker in ophthalmic preparation and a beta blocker orally, because again, the total absorption you get from any ophthalmic preparation is going to be minimal, but it could be enough to cause some toxicity or to cause some potential problems. So we want to try to avoid that if we can. However, again, it's just a precaution. I want to stress it's not an absolute contraindication or anything like that. And then the bottom part is sort of a matching thing, which I wouldn't do in an exam, but because we're in a lecture here, we can do this. So what possible side effects with each agent? I didn't necessarily line them up exactly here. So you have brown, so we can just start here. You've got bimatoprost, and that's going to cause the brown discoloration of the iris, potentially, in some patients. Betaxolol is our beta blocker. Remember OLOL? Remember that suffix there? That is going to be all the beta blockers are going to have something like that at the end, at least LOL at the end. And cardiac effects would be what potentially could happen with those. Orthostatic hypotension would be something you would see with an alpha blocking agent like dorzolamide. Timolol would also cause cardiac effects, because it's a beta blocker, but dorzolamide is usually given in combination with a beta blocker as that particular product Cocept. And olpatadine is that's an antihistamine, so we wouldn't use that for glaucoma at all. But it's not going to cause fixed small pupils. So what would cause fixed small pupils? That'd be our cholinergic agents that we really don't use unless somebody's not responding well to anything else. Okay, so switching gears from a little bit of review to respiratory. I like respiratory a lot. I just think inhalers are kind of interesting. One of my favorite parts about the whole treatment of respiratory diseases, a lot of it gets delivered directly to the site you want it to in the body. So side effects are minimized, from a certain perspective, as opposed to pretty much every other disease where we're giving something systemically and that drug can go all over the body and do all kinds of things you don't want it to. In this case, your drug is really just going to the lungs, and so therefore there's minimal collateral damage from the medication. So I think that's kind of cool, and I think the inhalers out there are pretty neat therapies. So I want to talk first about inhalers and the couple different types there are in the market. They usually come as one of two major types, which are the metered dose inhaler or the dry powdered inhaler. And I put a soft mist inhaler, you can put a star by this one or whatever if you want, as something that's a newer therapy. It's basically kind of like a metered dose inhaler, but a little bit different. We'll talk about that in a minute. But basically you have two types. You have aerosolized solution versus a dry powder you need to inhale. I would stress that common sense doesn't necessarily apply to inhaler use, especially if you've ever watched like a movie or a show where somebody's using an inhaler and thought, oh, that's, just kind of puff on it. Well, it's a little more complicated than that. So I think education, I would highly encourage you to get a respiratory therapist involved. Whether you're discharging from somebody from the hospital on a new inhaler or they're in clinic with you, I think make sure that the person gets adequate inhaler education is really important, because if they aren't compliant with their inhaler, or maybe they're trying to be compliant but they aren't using it correctly, that drug's not going to get to the correct site of action. Therefore, it's not going to be as effective as we want it to be. I'll let you watch this video on your own if you want to review how to use the metered dose inhaler. Sometimes these are also called HFAs, which I think is high flow aerosolized, but I'm not entirely sure. Don't quote me on that. But these are the ones that are going to be more of a liquid aerosolized product. So they're usually kind of compressed in a compressed small canister, and when you press them, they eject a kind of aerosolized stream of solution. The big thing with these is you breathe in, excuse me, sorry. You want to breathe slowly. That's the big takeaway from this. This is not something you puff on really deep and fast. You want to breathe kind of this slow, steady breath over a couple of seconds. That's going to allow the product to really get into the lungs where it needs to. It's heavy, so once it gets into the lungs, it should sink down. But the problem is if you pull too fast when you're breathing in, if you breathe in really hard on an inhaler like this, you're gonna get some of it into the lungs, but a lot of it's just gonna go right to the back of your throat, and you're gonna swallow it. So to be able to breathe in while the inhaler is going down is how to do it. Now, a lot of people with this particular type of inhaler use a spacer because it's a little bit easier to maintain. So a spacer is basically a big piece of plastic you stick on the end of an inhaler, you spray it in to the spacer, and then you inhale the contents of the spacer. It's a little bit easier to manipulate because you don't have to sit there and try and figure out how fast you need to press it down, because if you press it down, it sprays it all into your mouth. How do you breathe slowly and do that at the same time? So it's really actually kind of difficult to do that unless you've used an inhaler for a while and you've got that technique down. Whereas a spacer is going to make it a lot easier for people, especially elderly patients and children will respond a lot better to a spacer. Dry powder inhaler. So this is going to be something you want to pull in air deeply and fast. So this is something where you want to breathe in once, deep and fast, and that's going to be because, one, these inhalers are breath activated usually. So when you click into them, they usually have like a gate of some kind where they need, you need to be sucking on them basically. Suction needs to be open them up to pull out the powder, and the powder needs to physically get pulled out of the inhaler by airflow. It won't just get ejected. So usually these inhalers are designed where they have little blister packs in between, and when they rotate to the one, you'll click it and it'll kind of pop the blister pack open inside the inhaler mechanism, and then that will be where your drug is. So again, sucking deeply and fast is the best way to do it, and you want to make sure your patients understand that. If you try and do it like a MDI where you're going slower, you're going to end up with a lot of that powder just in your mouth. It's not going to, and then you're going to it's going to mix with your saliva and you're going to swallow it. The other problem with that too is a lot of these medications that we use for respiratory disorders contain inhaled what we call ICSs, or inhaled corticosteroids. And corticosteroids, remember, have an immune suppressant effect. And if you're continuously getting that into your mouth and exposing your oral tissues to that, you can end up with reduced immune system response, and people can get thrush and things like that from using inhalers. So they do recommend rinsing afterwards, regardless of whether or not you use good technique or not. But that is one risk you would run with chronically not breathing deep enough, is that you just get it into your mouth. Now, the nice thing is, between these two inhalers, there's different brands that use different ones. So there's pretty much every class of medication you can think of within a different type. So you don't have to really pick and choose. It's not like, well, I really want this patient on anticholinergic and there's only dry powders on the market. Well, there are some anticholinergics that are different than dry powder, but by far and away, the dry powders are the most common ones for chronic controller medications. So medications people are using, inhalers people are using every day, are going to be dry powder inhalers for the most part. There's a couple brands that aren't, but that's going to be the majority of what you see. So this is probably the more relevant discussion point. However, MDIs, the most common rescue inhaler, albuterol, is an MDI for the vast majority of albuterol preparation. So that's something too to think about as well. So most patients will probably have both types of inhalers, so they'll need to know how to use them differently. So what about these soft mist inhalers? Well, this is a new thing called a Respimat. It's really like an MDI with slower moving particles that last longer, and it doesn't necessarily change the way that a patient uses it. It's still a slow, deep breath, but it does stake around in the lungs a little bit longer, so that the particular drug can have a longer duration of action is the biggest benefit from my understanding. Now, there have been clinical trials to show that the patients do improve, the adherence is a little bit better, and that might just be because they don't have to take it as many times a day with these. But so there are some products that are available in this particular format. So if you see something branded as a Respimat type inhaler, that's not a drug, that's just the inhaler type. That's something that you'll know as a soft mist type inhaler, which again is just really an MDI, but it's slightly advanced. You will notice with inhalers, you'll see things branded as the inhaler, which is gets a little confusing. So for example, there's the Ellipta products, there's the Discus products, but those aren't drugs. That's just the type of inhaler. So you can have a Flovent Discus, you can have an Advair Discus, you can have a Brio Ellipta, you can have a Incrus Ellipta. There's lots of different types of inhalers. So it's like each company, when they make an inhaler, they brand that inhaler device. And one reason why respiratory care is a little tricky, especially from a cost perspective, is because inhalers are expensive, and a lot of times it's not that the medication is expensive or on patent or not. It's usually off patent, but the problem is that these inhaler devices stay on patent for a long time. So if I'm Glaxo and I make the Discus product, it might take quite a while for my patent on that physical device, and maybe it doesn't go up at all. And so if I'm a competitor, I can't mimic exactly what that physical device is. I have to get creative and try and figure out a different type of device that delivers the same type of product. So that's where inhaler design is really tricky. Okay, let's talk about the actual drugs here. First, let's talk about short-acting beta agonists, or SABA. So SABAs are really the mainstay of our acute system. So these are often called rescue inhalers by patients. There are two major drugs in this category, albuterol and levoalbuterol. Albuterol is by far the most common one. In fact, anyone with any respiratory disorder is going to probably have an albuterol inhaler, or they should have an albuterol inhaler within reach. Now, one of the things that this drug causes is not only does it open up, remember it's a beta agonist, so it should primarily work in the lungs. However, the lungs are highly vascularized, and anything you put into the lungs is probably going to absorb systemically a little bit. And this is not certainly the case with albuterol. So when somebody takes a few puffs of an albuterol inhaler, what will happen is some of that will get absorbed systemically, and albuterol does have some effect on the beta-1 receptors as well as the beta-2, and that increases the heart rate. So people who use albuterol will feel tachycardic. This is short-lived and usually doesn't last very long, but it certainly can be problematic, especially if somebody's already anxious from having an asthma attack or something like that, and they're increasing their heart rate that way. The other drug, levalbuterol, some people think that this medication causes less tachycardia, but it actually hasn't really been clinically proven to do so. It's more of a, I think of it almost like a placebo effect when somebody claims that it doesn't cause that. It's not different enough where it wouldn't, but again, some people kind of think it does. It came out a while ago. Its brand name is Xopenex, but it's pretty expensive compared to regular albuterol, and most people don't use it. So I would discourage you from prescribing anyone Xopenex unless they're using their albuterol a lot and it's giving them a lot of problems. But in that case, there's probably another issue at hand. Why are they using a rescue inhaler so much? Most people shouldn't be using their rescue inhaler enough where they would get chronic cardiac side effects. They're going to make a problem for them. So that's another thing just to keep in the back of your mind. These are designed for ideally like never to be used at all, but maybe once a month or once a week or something. But if you're using it every day or multiple times a day, that's a sign of uncontrolled respiratory disease. Directions, both of these medications don't last very long, so if you're going to chronically give somebody albuterol, you're looking at every 4 to 6 hours. If you're experiencing acute exacerbation, you can take quite a bit of this at once. I'll talk about that in a second. There's also a nebulization solution available, which is quite concentrated compared to the inhaler. So if you take a puff off of an albuterol inhaler, it's 90 micrograms. An entire neb solution is 2,500 micrograms. But think about a neb isn't perfect. A lot of it's getting, when you nebulize something, a lot of it gets kind of thrown out into the air. So how much you're actually breathing in is debatable, but it's certainly going to be a lot more than 90 micrograms. So when somebody's having an exacerbation, if they're like, I took 2 puffs of my albuterol and it didn't really work, you can take quite a few more than that and still be significantly under what you get during a nebulization treatment. Albuterol has a really fast onset. You're talking about 5-10 minutes, which is probably long. I mean, if it gets into the lungs fast, it should start working, I would say, within a minute. It should work almost instantly. And again, it's quite short acting, so we don't use this regularly. In fact, regular use is a surrogate marker for disease severity. So one of the questions they'll ask is, how often are you using your albuterol inhaler? And then, if you're using it daily or more, that's a likely sign that your disease is not controlled. Okay, so long-acting beta agonists, these are the same mechanism as the SABA, they just last longer. There's a bunch of different ones on the market. They all end in ROL, or again, OL, so you can kind of remember that they're beta-like. Now, these aren't beta blockers, so remember no LOL, but they do have the ROL somewhere. And they're in a number of different brand names. So I've tried to put these different brand names on here. Most of these have like a 12-hour duration or so you're looking at twice a day. The newest ones, olodaterol and vilanterol, are once daily dose. So they're a little bit longer acting. The one we use in the hospital primarily is Brio or vilanterol, which is the one I'm most familiar with. But certainly there's a bunch of different options out there that are pretty common. Advair, for example, the brand name combination product, has been on the market for a number of years, and that's one of the most popular choices out there. One really important thing, not acutely used, however, there's some asthma guidelines updated for asthma. I'll put a question mark here. We're going to come back to that. Don't take that one to the bank because this is actually technically not true anymore, and I'll talk about this in a second. However, generally speaking, these don't have a fast onset, with the exception of formoterol. So formoterol is the only one that you can actually use in an acute situation where you really need something to work quickly. It almost has the same onset as albuterol, and then it lasts a long time too. Problem is there's only 2 products on the market that have formoterol in them, Symbicort and Dulera, and they're relatively brand name and somewhat expensive. And they also come in combination with a corticosteroid. So you don't really have Foradil as a product, but I don't know if they make it anymore. I've actually never seen just a standalone Foradil, but certainly it could be something available. It's just, again, I've never seen it. So we need to focus on that's really just the difference with that one product. Otherwise, all these are basically the same thing other than formoterol. With asthma patients, we do not use these drugs alone. In fact, mortality has been shown to increase if somebody does take a long-acting beta agonist without a steroid. So that is a contraindication for monotherapy in asthmatic patients. That's a big difference between treating COPD and asthma, and we'll come back to that here in a few minutes. Inhaled corticosteroids block late phase reaction to allergens. They reduce airway hyperresponsiveness and inhibit inflammatory cell migration and activation. They're our first line of long-acting therapy in asthmatic patients. And we talked about the mouth rinsing thing. They don't really have much of a role in acute treatment. They don't work quickly, just like our nasal sprays. However, there is some more evidence that they should be started earlier in treatment than what we have been doing in the past, and we'll talk about that in a second, so get back to that. Some people recommend supplementing calcium. We talked about steroids in a previous lecture and how osteoporosis is one of the complications. It's not thought to be a significant one with inhaled corticosteroids because you don't absorb enough really to make a difference, but it is something that some people take into consideration and may be interested in prescribing their patients. And supplemental calcium is relatively harmless, so it might be worth doing, especially if your patient is higher risk for osteopenia or porosis. And here's a nice little chart with all the inhaled corticosteroids. As you can see, there's a couple different preparations. So for example, there's Qvar, which is beclomethasone. This is a meter dose inhaler. You have Pulmicort, and then Flovent was one of the first products that's inhaled fluticasone. That is also comes as a discus, which is a dry powder inhaler, and also comes as an aerosolized meter dose inhaler, so you can get both different types of presentation that way. And then you have the newer products, the Brio, or sorry, not the Brio. What is this one? Arnuity is what they call this one, and that's the Ellipta product, which is a little bit different. I do have some of these that I might bring in the next time we meet. Hopefully, we can do a face-to-face sometime if you guys want to see them. I don't know if you guys have a respiratory lecture where they actually bring in inhalers and let you play with them a little bit. I think it's nice to see them in person. But basic concept of inhaler. Dry powder specifically, and you can't really see this, but you can zoom in on your computer or whatever you want to do, blow up my picture a little bit, or Google it and look at it, or watch the video that I included. But anyway, what you're going to see is this little tiny white thing over here is a dose counter, and you see that in front here on the Ellipta products quite a bit bigger. You can see the 1.4 here. So that's nice because it tells your patient how many doses they have left. In fact, if you didn't have a dose counter, you'd be kind of blind and wouldn't have any idea when to refill your drugs, which would be problematic. So they have the dose counters on them. The Advair product's a little more complicated. It was the old one, or I should say the Discus products. What this is, so this is the mouthpiece. Generally speaking, this disc slides. So if it kind of cocks back and locks into place, exposing the mouthpiece, and then you can pull this trigger back, and that opens the window medication, and then you would inhale off of the mouthpiece. You kind of hold it right up to your face like you're eating a hamburger and do it that way. And then the mouthpiece, once it's done, you just kind of slide it all back, and the mouthpiece gets covered by this darker colored disc here. Not super complicated. It's relatively easy to use, but it does require manipulating some levers and things like that. The Ellipta products are newer, and they're actually made by the same company. So this is sort of their new and improved version. And this big thing on the top gets pulled back and slides all the way down here, and you get the mouthpiece that's exposed here. Same general concept. However, once you pull this back, it cocks itself into place and opens up the window. You don't have like a little lever to press separately. So it's less manipulations. Also, it's a bigger piece of plastic, and it's hard to get this visual here, but it is easier, I think, to manipulate, especially if you have like an older patient who's diabetic and maybe has lost some feeling in their hands or something like that. They might struggle with using a smaller product, whereas the larger inhaler with the bigger, easier to grab lever would be easier for them to use. So, and a lot of this stuff is just a little more patient friendly. Again, you really don't care about this stuff as a patient. You want to see, how many doses do I have left, and can I use my inhaler? And so that's much bigger on this product. So again, they've worked to improve some of this stuff over the years. These two drugs have historically been the mainstay of treatment for respiratory disease in general, and because of that, they've been combined into different products with long-acting beta agonists and steroids kind of making the bulk of what we see and dispense in pharmacy. And there's a couple major ones in the market. Advair was it was the big one for a long, long time. It was this purple disc. And that was really what everyone was using for a long time. And then a bunch of other ones kind of hit the market. Symbicort came out. Symbicort is an aerosol, so it's a meter dose inhaler. Dulera is a meter dose inhaler. And then the Brio products came out too. Or I should say the Ellipta products came out too. And those are there too. And you can see they all use slightly different ones. Like Advair uses fluticasone. Brio uses fluticasone. Symbicort uses budesonide. Dulera uses mometasone. And then they all have varying degrees of what they different products they use that are the long-acting beta agonist. Probably from a convenience perspective, the Brio products are quite popular because they're a once-daily inhalation, whereas everything else is BID. Inhalers in general are all pretty inexpensive. I mean, you're generally looking at like a cash price of a few $100 per inhaler. It doesn't really matter what brand you're looking at. You know, one might be $400, one might be $500, but they're still both, you know, several $100s. It's not like one's super cheap. The only relatively cheap inhaler out there is the generic regular albuterol rescue. And unfortunately, that's the one we don't want our patients to take every day. So cost can be an issue with these, especially when you get these newer brand name products on the market. Systemic corticosteroids are generally not useful for regular maintenance therapy for asthmatic patients or for COPDs. They're really only used for exacerbations, and we give them in bursts, generally not more than 10 days. Maybe up to 2 weeks if it was severe, like recurrent, but usually we're probably just cutting the patient off with just giving them a standard dose of like 10 days, cut them off, don't do any tapering or anything like that. Prednisone for asthma is a little bit higher dose than COPD. And again, you can see it's a relatively higher dose. Compare this to what we talk about with like transplant patients. You're looking at a dose of like 5 to 10 milligrams a day, maybe closer to 5. And so this would quite a bit bigger. So you're looking at 40 to 60 milligrams every day, 3 to 10 days, maybe up to 2 weeks for COPD. Some people will give a higher dose of steroid in the acute phase. So if somebody comes into the emergency department or urgent care with an asthma exacerbation, they might start them on like an IV methylprednisolone, give them a dose of that. So that's 125 milligrams of steroid IV or IM. And then they would transition them to a oral dose from there. So that's just to make sure that they get a nice burst of steroid. And remember, once you start this, you don't really have to taper it off. The body can handle steroids for a few days before it starts suppressing its natural cortisol production. So again, as long as you aren't going over 2 weeks, you're probably okay. Some people will taper, some people will feel more comfortable with that, but you know, that's a personal choice. I would say it's not recommended to do that. Okay, that's all I got to say about that. The next class and the final class we'll talk about for inhaled medications are anticholinergics. Anticholinergics are also called LAMAs, or long-acting muscarinic antagonists. And these are going to be your other category of bronchodilators. So COPD often refers to, COPD guidelines and recommendations will say start somebody on a bronchodilator. What that means is either an anticholinergic or a long-acting beta agonist. So again, what these are going to do is reduce intrinsic vagal tone of the airway via muscarinic receptor inhibition. Also, they might reduce some secretions as well that could be contributing to the inflammatory process. For a long time, these were only used in COPD. However, they've actually gotten added on to the asthma guidelines as a late option for people who aren't responding to standard therapy. Mechanistically, there was never any reason why they couldn't have been given to asthmatics. They just were never really studied, and they were marketed towards COPD. As a cash cow product, Spiriva or tiotropium was the first drug on the market, and for a long time it was the only option that was a long-acting anticholinergic. So basically, if you were a COPD patient, you were on Spiriva, and there wasn't really another choice. So that drug was hugely successful. It took a long time for anyone to really have a alternative to it. Now there are a couple other ones. Spiriva actually came out with its own different formulation called a Respimat.
I'll skip Atrovent for a second. There's a Turdoza, which is aclidinium, and there's umeclidinium, which is Incruse. Incruse, I don't have a picture of it, is a ellipta product. So it looks like the Brio inhaler we just talked about on the other slides with the big lever on it. So that's part of that family of drugs. That's a once daily. So is tiotropium, whereas the aclidinium is twice daily. Ipratropium or Atrovent is a short-acting anticholinergic. This is something that sometimes people will schedule. Like, this was probably more so when people couldn't really afford tiotropium, and this was the only other option. They would schedule it like 4 times a day. You would take an Atrovent inhaler. Some people use Atrovent as a rescue medication too, but it doesn't work quite as well as plain albuterol. And usually, if they're going to do that, they would combine it with albuterol. It also comes as the combo formula as a nebulized product called DuoNeb, which is ipratropium plus albuterol in a neb. That's really popular for inpatient use for patients who need aggressive bronchodilation immediately or regularly. They'll usually do, and it's really cheap to neb stuff in the inpatient world versus giving them an inhaler to use, which is generally expensive. So if I can spend, if you think about somebody on 4 times a day nebs for a 7-day hospital course, that's going to cost my pharmacy like less than $10 of cost probably, versus an inhaler is going to cost us $300. So that's one issue that we run into where nebs actually, because it's so easy to give them in the inpatient setting, tend to be preferred. But we still, it's not like we don't prescribe inhalers, we do, but it's just something to think about when you're looking at different settings. But at the end of the day, ipratropium is generally it's a short-acting medication for sure, and it's generally used for more acute situations than chronic. But it does have some chronic use. It's just not really a product that's out there as much as it used to be, I should say. There are some combos available that include anticholinergics. There is tiotropium and olodaterol, which is a combined long-acting muscarinic antagonist plus a long-acting beta agonist, and that's Stiolto. And then the one we carry in our hospital is Anoro, which is umeclidinium and vilanterol. There's also fluticasone, umeclidinium, vilanterol, which is Trelegy, which has all 3 products in it. It's only inhaler on the market that has a triple therapy in one, which is kind of cool for somebody, especially for somebody who's on all 3. It's nice not to have to take 3 different inhalers. So that one's kind of an interesting market choice there, and surprised that no one else really has a product like that since it's pretty popular for COPD management. The reason why these products came out with a combo, these are a little bit newer, is the guidelines for COPD more recently, like within the last couple of years, said that you could use both. Previously, it had been like you should be on one or the other. You don't need to be on both bronchodilators. So pick a long-acting muscarinic antagonist or pick a long-acting beta agonist, but you don't need both. And now they've changed that to say, actually, people do benefit from having both, and people benefit if you throw on the inhaled corticosteroid to a certain degree too. So they've changed their tone on that a little bit, and so both of them get used together a lot more than they used to. So that's why we're seeing some of these combination products that are a little newer that have the 2 and 1. I just want to talk about the Spiriva Handy Healer really quick. Again, this is kind of phased out because people don't use Spiriva quite as much as they used to. But the Spiriva Handy Healer was a super complicated thing. Basically, you'd get an inhaler device, and then you'd get capsules, which came in blister packs. So you'd actually have to take the capsule out of the blister pack. You'd have to pop this thing open, and you wouldn't. Not only would you have to take the top part of it off, but you have to pop open the mouthpiece as well. You put this capsule in this little hole, and then this little thing on the side was actually like a spike that would go through and pierce the capsule. Once the capsule was pierced, you would inhale through the mouthpiece. You'd usually do it twice to make sure you got everything, and that would suck the powder out of the capsule. Super complicated and way more annoying than anything else on the market, which is why, one, again, I'm surprised this product lasts as long as it did. No one came up with an alternative. But 2, it's sort of fallen out of favor now that we have inhalers that are much more mainstream and easy to use, like our standard of care, versus something kind of oddball like this. So there you go. There's the Handy Healer. Not handy, in my opinion. And again, this is just a picture, a little bit more detail of the Ellipta inhaler and how, like, where we've come from and how this is just much more easy to use. It's got an air vent on it, so it's really easy to pull air through so that you're getting all the powder out. And then again, this cover, it's one mechanism. It's really, really easy to manipulate compared to previous inhaler iterations. I've got a few videos on here for neb treatments in case you're curious about how it all works. They're generally preferred in pediatric patients because you can just strap the neb onto them while they sit on a couch or something, I guess like this kid is doing, and they can breathe somewhat regularly, and they're just getting the medication that way. Whereas for little kids, inhalers could be really tricky to do. I mean, nebs for little kids are going to be tricky to do. Strapping on a mask and turning on a pump that's really loud while a kid tries to breathe normally and they feel sick is not ideal. But it's probably better than trying to get them to use an inhaler, which might be borderline impossible to figure out how to get a kid to use an inhaler correctly anyway. So again, there's a couple videos there. Some of them are kind of funny, so feel free to enjoy if you want. So that kind of concludes the respiratory meds. We'll talk about guidelines here in a second, but what I want to talk about is a couple other random drugs. There are some drugs that block the effect of lipooxygenase. So if you remember lipooxygenase, that kind of works like cyclooxygenase. It's in that same pathway, but it activates leukotrienes. So by blocking it, you're blocking the leukotriene response, which blocks part of the allergic pathway. And you don't get great patient response from everyone, but some people do really respond well to them. They're relatively well tolerated as well, except they can cause headaches. That's really the only major side effect they have. The drug targets, there's a couple products that target leukotriene receptors directly as antagonists. There's montelukast and zafirlukast. Montelukast is super popular. It's been around for a while. It's been used regularly. So people who have a fairly high allergic component to their asthma, this is going to be a drug they're going to be given. Usually not used in COPD patients, but for asthmatic patients, again, with allergy-related symptoms, that's going to be a pretty popular choice. LOX5 or lipooxygenase 5 inhibitors, there's a specific one called Xylutin on the market that is there too. So I wouldn't worry about these too much outside of Singulair. That's the one I would know. Montelukast, it's a really important one because it's just very common, and it's really the one, if you're going to prescribe this for a patient, you're probably going to prescribe that one. The only reason you'd use the other two is if the montelukast isn't working or for some reason the patient's not tolerating it well. Xanthine derivatives are kind of an alternate bronchodilator. We don't really know exactly how they use. Caffeine, for example, is a xanthine derivative, so if you're curious what that means, that's part of it. So kind of think about how that works. But it does dilate the pulmonary tissue, which is good in this particular case. We don't really use it a ton. It's more of a last line therapy, and basically it would be if somebody has having an acute exacerbation, you might try giving it to them. Now, some people do take it chronically as an oral form. Theophylline does come orally, and people who have COPD may use it regularly. It's, again, kind of rare. It's not a really common medication, but it is something that might be added on to a COPD as an adjunct therapy to complement their inhaled therapy. Or if patients are having a really hard time with inhaled therapy, it's nice to know there are at least some oral alternatives, even if they aren't, maybe don't have the greatest evidence associated with them. At least you could maybe give it a shot, and then they're at least getting something versus using an inhaler incorrectly and not really getting anything at all. Finally, there's a product called Xolair or omalizumab. It's an IgG monoclonal antibody, as you can say by the name MAB. It inhibits IgE binding on mast cells and basophils, basically limits activation and release of allergic response mediators. And this is for patients with pretty severe allergic asthma. They get it every 4 weeks. It's weight-based dosing, and you can use it in pretty young people, but technically not studied in kids under 12. So this would be somebody who has severe allergic reactions, possibly causing asthma, and they maybe aren't just responding to other things aren't working. Inhalers don't work. You really need to get at the source of the problem, and that's where this comes into play versus trying to cover it up with managing the symptoms. This is actually hopefully prevent the exacerbation from happening in the first place. It's really expensive, but it is indicated for some patients. All right, let's talk about asthma specifically, and then we'll talk about COPD. So asthma, if you're curious of where the big guideline producers for asthma, it's GINA, G-I-N-A. If you go to that website, you can read all about it and look at cards and updates. And I mean, like, by cards, I mean, they usually have like an executive summary that kind of neatly says like how to treat asthma based on their recommendations. So anyway, they're kind of the boss when it comes to anything asthma related. Basic asthma stuff, chronic inflammatory disorder of the airways. You have waxing and waning airflow, hyperresponsiveness, It's relatively common. It's one of the most common childhood illnesses. So if you work in pediatrics, you're going to see asthma a lot. It's responsible for a lot of hospitalizations and emergency department visit. Death, fortunately, is really, really rare. If you get to an asthma exacerbation within a decent amount of time, you can treat it. It's very easy to treat, and most patients respond quite well. Ultimately, patients might end up needing to be intubated if it's really bad, but generally speaking, I don't know if I've ever seen an asthma exacerbation get that bad. Usually we have enough tools in our belt that if we can react aggressively and have good respiratory therapy in hand, we don't usually need to intubate somebody. We can keep them breathing on their own and give them some aggressive nebulization and stuff like that. So anyway, it's very preventable, though, if we use controller medications and follow guideline recommendations correctly. Here's a drawing for you guys in case you want to see swollen airways. Asthma triggers. So what can you do to prevent asthma? Certainly household triggers. If tobacco smoke, wood burning stoves, chemicals, like if somebody's doing a remodel or a renovation, that could certainly contribute. Pets, mold, dust mite, cockroaches, rodents, that all those can be triggers as well. So that might be the first step, is taking care of some of these issues if somebody's having chronic asthma. Outdoor allergens, certainly seasonal things. Asthma can be very seasonal. Some patients may not get any asthma symptoms on off seasons, but in certain seasons they really do get hit hard, and then they might need a medication temporarily, and then maybe they go off a bit later. I've seen that happen quite a bit. Other medical conditions like allergic rhinitis. If you have a bad cough, it can cause sort of a postnasal drip, which can lead to almost asthma-like symptoms that should resolve as the symptoms fade, though. GERD, so chronic gastroesophageal reflux disease. So if you aspirate food chronically, that can get into the lungs and cause damage and inflammation, and so that can actually be an asthma trigger as well, which is interesting. So managing that particular disease would certainly be important. Medications, beta blockers. Beta blockers are important to think about in asthmatics because one, if it's a non-selective beta blocker, it can work on the beta 2 receptors in the lungs, which can cause the opposite of what we want. So it can actually block the body's ability to have bronchodilation, which can be a problem. And maybe even the worst problem is if somebody's on a beta blocker and you try and give them a beta agonist to treat their symptoms, if they're having an exacerbation, they can end up the medication can end up not working because the receptors are already blocked and there's nothing that the drug can do at that point, or minimal amounts of effort, or minimal effects the drug can have because the majority of those receptors are blocked by an antagonist of those particular receptors. NSAIDs. So NSAIDs, I've mentioned these a couple times, but just a reminder, these are non-steroidal anti-inflammatory drugs. These are ibuprofens, naproxens, Aleve, Advil, etc. Really common OTC pain meds. And so the reason why these are problematic is they shut down the body's natural production of prostaglandins and prostacyclins, and those can have some vasodilatory and bronchodilation effects that way. And so with NSAIDs, they can actually have a problematic effect on asthmatic patients. So it's not that asthmatic patients can't take beta blockers or NSAIDs, but we just want to be careful with them if we're going to use them in an asthmatic patient. Oh, and here's my funny picture of a cat getting a neb, which is a real thing, I guess. It's like a really tiny face mask, kind of cute. All right. So our goals of therapy, we want to reduce impairment. So impairment of intensity and frequency of symptoms. We want to improve quality of life. You can see kind of the list there. I'm not going to go through it. And then reducing risks. So keeping people out of the hospital, keeping their lungs healthy, making sure they can do things on a daily basis that they want to do. That's really the goals here. Monitoring. So when we break down symptoms, this is usually what we're trying to target. So if somebody has intermittent asthma, that's usually about the best they can get. And this means that their symptoms are happening less than 2 days a week. Nighttime awakenings are 0 to maybe occasionally a month, but rare. They aren't interfering with any of their normal activities, so they're doing quite well overall. Their lung function from spirometry readings, which I'm not going to go into spirometry, by the way. So this is more, hopefully you'll get some of this from a respiratory therapist or in other modules, but it's not really my thing. So if you need to look this up or go to another class, feel free to, but I'm not going to go into it in my class. But anyway, spirometry readings are there and what you might see there. And asthma exacerbation requiring oral systemic corticosteroids happen less than one time or less a year. On the SABA use, the short-acting beta agonist is less than 2 days a week.
which would generally correspond with symptoms, right? Once you get higher up in the asthma category, you're just really adding on more symptoms here and more, use of your inhaler, more limitation in daily activities, and those types of things. These are the 2019 guidelines, but as far as I can tell, there's not really been any major changes. 2019 was actually a pretty big year for the asthma guidelines, and it changed a lot. And actually a few decades, they're pretty much the same, with minor changes with new drugs and stuff like that. But that's really it. This was one of the bigger changes out there, and what really is the step 1, which is the as-needed low-dose ICS formoterol therapy. What they're advocating for now is that you give inhaled corticosteroids earlier in therapy. So, and actually now they're recommending starting all asthmatic patients on controlled or on a controller medication, which in this case would be an inhaled corticosteroid. So just to back up a little bit, with asthma, one of the big things to remember is that inhaled corticosteroids are always our first line controller long-acting therapy, which is the biggest difference between that and COPD, where ICSs are kind of last line add-on, or we try not to use them at all because they actually have some risks with the COPD population that have been shown in the last few years. So anyway, Gina in 2019 came out and said, well, we used to say, so what did step 1 used to be if this is such a big change? Step 1 used to say, if your asthma is well controlled, all you need is a short-acting beta agonist. Just have your albuterol on hand, take a puff of it if you get a symptom, and that's it. Well, there's been some evidence that actually looks at the patients with mild or even really light intermittent symptoms and shows that even those patients who have relatively well-controlled asthma do well on a low-dose inhaled corticosteroid over time. So what the guidelines are saying now is that, well, you just start somebody right away on the low-dose inhaled corticosteroid. So that's what step 2 would actually say. So actually pushing that earlier. But they're also saying that, well, if you don't necessarily have to do that, you could do an as-needed low-dose combination product. But what they aren't saying anymore is that you can use a short-acting beta agonist by itself. And that's the biggest change. So no more just puffing on an albuterol inhaler twice a month when you get symptoms. You should either be using a low-dose inhaled corticosteroid daily, or at least taking it every time you're going to use that short-acting beta agonist, or using a combination. So in this case, they're saying use your as-needed formoterol. Remember, we talked about formoterol being a longer-acting, a shorter onset. So it works in about 5 minutes, long-acting beta agonist, and then in combination with an ICS. So taking that one of those products like Dulera or Symbicort would be the brand name combinations there, and puffing on those instead of your albuterol, or using the albuterol, but at the same time taking, using a dry powder inhaler like a fluticasone or something like that, in addition to your albuterol every time you have symptoms. So that's been the new recommendation to come out, and again, that's a pretty big change. One of the big controversies with this is a lot more expensive. So for people who have not the best controlled asthma, this is something that they need to probably consider, and if that's the case, then they might not be able to afford it. So that's where the question comes in: do they have to, what choices do you make to make sure somebody can actually afford their inhalers? Because you're going up in cost from $15 for an albuterol to $300 for a Symbicort. That could be substantial for a lot of patients. So that's one of the big problems with this current setup. So anyway, that's what the guidelines are recommending now. They're basically saying that anytime you give any beta agonist, you need to have an inhaled corticosteroid at the same time. So that's been the big change. Otherwise, it's all pretty much standard. You're starting with low-dose inhaled corticosteroids, and as symptoms get worse, you are doing low-dose inhaled corticosteroid, adding on the beta agonist as a daily, then increasing the step there, and then eventually you go to high dose. And you can actually consider, I think they say it on here. Do they have it on here? Maybe they don't. They used to have it on here. Maybe they took it off. Anyway, they said you can consider a long-acting antimuscarinic agent too for uncontrolled, which would make sense. Again, that was something that for a long time we didn't really have evidence on, and there is some evidence that asthmatic patients respond well to that. All right, so that's really what I want you to know as far as guidelines for this test. I want you to be able to recognize that, you start, if I gave you a patient at some interval in here, I would say, the patient's been on a low dose inhaled corticosteroid and they're having more symptoms. What would you do? Well, you'd go to the next logical step, which would be to add the long-acting beta agonist on. I'm going to try not to muddy the water with the guideline changes, because I think you're going to still see a lot of things in practice where people just use the short-acting beta agonists because they're cheap and they're effective and they're going to prescribe somebody an as-needed Symbicort. But you might see that change as these guidelines get more established. All right, exercise-induced asthma would be something causing bronchoconstriction during exercise. It usually starts about 6 to 8 minutes after exercise and resolves 1 hour after completion. Causes shortness of breath, chest tightness, and cough. Beta agonists work quite well. So some people will take one or maybe inhale something like albuterol 10 minutes prior to exercise. Formoterol might be a better choice if they're doing something long, like if you're running a marathon or something. Maybe formoterol makes more sense, but albuterol is probably fine. People tend to build up tolerance to the long-acting agents if they use them regularly, so that could be a problem to consider as well. Steroids would be something to consider only if they're having exercise-induced asthma because their underlying asthma is poorly controlled. In that case, they should be on an inhaled corticosteroid anyway. The other one some people will take, especially during allergy season, is one of the anti-leukotriene agents, so like Montelukast. Take it 2 hours before, 2 hours after. I think that means 2 hours before. You wouldn't really take it after exercising. That probably doesn't make any sense. 2 hours before exercising. And it's just a single dose. So that's something that, again, if somebody has seasonal allergies in the spring that causes some exercise-induced asthma, it would be a good choice for them. Or you can just take a tablet maybe once a day in the morning and then go with that. So that's one option too. Exacerbations, we're going to talk about this a little bit more detail during emergency medicine, but just to touch briefly on it now, you really are using nebulized treatments of things we've already talked about aggressively. So albuterol ipratropium nebulizers, oxygen, consider IV steroids, so like methylprednisolone, IV or IM is our drug of choice, generally speaking. One thing that is done in addition is magnesium sulfate. This is an IV magnesium you can give. And this is really if nothing else is working and you're looking at life-threatening or going to have to intubate the patient, this is something they might try. It's sort of a broad spectrum smooth muscle relaxant. And then everything else is dependent on what else is going on. So if somebody has having an anaphylactic response, something like epinephrine diphenhydramine famotidine as part of your antihistamine and vasopressor response would be indicated. So you want to make sure that is taken care of appropriately, but you also want to make sure their respiratory part is supported correctly. You can give IV methylxanthines like aminophylline. It's a little controversial, but it would work in a last-ditch effort. I don't think I've ever done that before, so it'd be quite rare to actually get to that point, but it is an option. And now we're going to go into COPD. So the COPD guidelines are the gold guidelines. So if you want to, again, look at that on your own, you're more than welcome to go and browse that website. I think it's all free. Both this and the GINA, I think, are all free, to the public to look at. COPD is a really common disease that you'll see managed frequently. It affects more than 5% of the population. It's high morbidity and mortality, and it's the third cause of death in the United States. A lot of resources are spent on COPD patients. Lots of hospitalizations, emergency department visits, or chronic medication and oxygen therapy as well, which isn't cheap. So there's a lot of money spent on COPD patients. Causes can be reduced lung growth, premature lung function, inflammation, but different than asthma. But for the most patients, I just made its own bullet point here. Cigarette smoking is the cause of COPD for the vast majority of cases. And other things are going to be probably genetic related, like genetically small lungs or poor lung growth or premature lung development in utero. Otherwise, environmental exposure could be something like if somebody worked in a lab or like an industrial chemical plant for years or something like that with bad protective equipment. But for the most part, people who smoke get COPD eventually. Most people, or the majority of smokers, will at least get some symptoms at some point. So that's going to be our biggest cause here. This chart just shows COPD with aging. So the red line and the blue line represent, red line would be somebody with normal lungs, and blue line might be somebody who was born, with premature lungs or just has, some sort of a genetic lung disorder. Anyway, the green line represents the decline you'd see with lung function over time if you have COPD. This would be maybe a more aggressive feature, and this would be maybe more what you would see like line D when somebody, slowly kind of diverging from their peers around the age of 40 after smoking for 20 years or so. I think a lot of times people get caught up with COPD is obstructive, asthma is restrictive, blah, blah, blah. They're all kind of connected. So I don't think it's really fair to say one's this way and one's the other, because they can both have aspects of inflammation and obstruction. They can both have aspects of restriction too, depending on what's going on. So I put this weird concentric circle thing up here because they do all sort of connect, in emphysema, chronic bronchitis, and obstruction in general all sort of have this general process that is all interconnected. Okay, so with COPD, 3 symptoms are kind of our markers for how well we're doing: dyspnea, cough, and sputum production. Wheezing and chest tightness would be more associated with an exacerbation, but patients' presentation for COPD is usually going to be sedentary lifestyle, and a lot of people might have been active and kind of slowly become more sedentary, and then they just didn't really realize it because it happened slowly over time. Now they don't really get much exercise or much activity at all, and it's because they get so out of breath whenever they get up or even walk, and it's because their COPD is slowly taken over and now is in a situation where they need treatment to get back, or to at least preserve whatever lung function they might have. Diagnosis can be kind of confusing. COPD exacerbations can look very similar to pneumonia, and they can also look really similar to congestive heart failure. Our goal of therapy is to preserve respiratory function. We can do that with pharmacologic therapy. We can also do it with non-pharmacologic options, so smoking cessation, vaccinations, which I guess is technically pharmacologic, right? Other risk factors, like if they're exposed to some sort of environmental thing, oxygen therapy, and pulmonary rehabilitation with a respiratory therapist are all really important aspects of COPD treatment that I'm not really going to go into. The GOLD guidelines recommend a couple things for pharmacologic treatment. So basically they separate people into a couple categories. So there's the 0 on this side. You have the 0 to 1 moderate exacerbations not leading to hospitalization, or more than 2 exacerbations or greater than 1 leading to hospitalization. I think that's within the last year or 2 is what that time frame is. Then there's a couple things over here. There's the MMRC, Modified Medical Research Council Dyspnea Questionnaire. And there is the CAT, which is COPD assessment test. Now, again, I don't really know exactly what these are. If you want to go to the GOLD guidelines, they do have examples of them. I kind of browse them, but I don't care that you know them specifically. But basically, depending on your score, would put you into the group, and then depending on how many exacerbations you have. So they do these survey tools plus exacerbations, and then they put you into one of these groups. And that's really how they stratify your COPD if you're the patient. So the best case scenario is your group A, and that's just a single bronchodilator. Now, what that bronchodilator is, they don't really say. It could be long-acting, it could be short-acting. Historically, people in group A have just been prescribed a as-needed albuterol inhaler, and that's it. That's what they really mean by a bronchodilator in group A. Now, because if you go to group B, it's a little confusing because they say a long-acting bronchodilator. Well, here they say a bronchodilator, here they say a long-acting. Could you use a long-acting bronchodilator in group A? Technically, you could if you wanted to start somebody on a long-acting. I don't think there'd be any problem with that, but you just have to have a justification for that. So I think at the end of the day, you could just follow the age-old COPD recommendation. Start somebody on the short-acting beta agonist as needed, and then once if their COPD progresses, then you'd go up from there. But certainly, if you want to be more aggressive at the get-go, you could prescribe a long-acting right away. I don't think there's any problem with that, and I don't think that'd be against the guidelines. So. Group B is adding your long-acting bronchodilator, and here you can pick a LABA or a LAMA. It doesn't really matter which one according to the guidelines. Group C says if you aren't on a LAMA now, you are now on a LAMA. And then Group D says
you either use LAMA, LAMA plus LABA, or ICS plus LABA, and then you can consider triple therapy at that point as well. But they don't actually say that here, but they do say that somewhere else in the guidelines. This chart, I think, is a little easier to look at. So kind of breaks it down into the different categories of what people are experiencing. So if dyspnea or exacerbations are your big one, you're going to start with the same category, so LABA or LAMA. From there, you're usually going to add an inhaled corticosteroid on or add the other product on. So from starting with one, you're going to add something. Now these green arrows are a little confusing because it doesn't tell exactly what they are. What this basically means, if somebody's having issues with inhaled corticosteroids, this is a de-escalation pathway. So you would take this away and then bring them into this group. Same thing with here. Why would you do that? Well, because inhaled corticosteroids have been shown to actually increase pneumonia risk in patients with COPD. They've also been shown to improve symptoms and to improve quality of life overall. So there's, a give and take here. So inhaled corticosteroids are okay to use, but you want to make sure that if the patient does experience a pneumonia or anything like that, you probably look at some sort of different treatment option for them. And then triple therapy is an option here. It's sort of all in here. And again, de-escalating based on if the corticosteroid is causing issues. So some patients will be on just the LABA-LAMA. Some will be on triple therapy. Some might just be on a single therapy, a single beta or a single bronchodilator, depending on how severe their symptoms are. Some things they do that are a little differently, and I think I address these later, but I'll just talk about them now because they're here. Azithromycin daily is something they might use in former smokers who have been having issues with not uncontrolled COPD on triple therapy. And in these cases, the problem with chronic azithromycin therapy is chronic resistance and problematic infections that might be caused by that. But it is shown to decrease exacerbations in that particular patient population. Roflumilast is another product we'll talk about in a little bit that's sort of an add-on therapy. It's an oral therapy. So the question comes up is these they pool bronchodilators together, but they tend to give a little bit of favoritism to the LAMA. And which one is better? The largest trials out there have shown that, generally speaking, long-acting muscarinic antagonists are a little bit better than our long-acting beta agonists. So salmeterol was proven, or tiotropium was proven to be more effective than salmeterol in a 2011 New England trial with a lot of people in it. But there are some other ones that were a little bit less conclusive, like this other smaller trial. Anyway, most of the recent studies and the continuing trend in evidence favor the long-acting muscarinic agent. So if you're going to pick one, generally the long-acting muscarinic antagonist is your drug of choice for COPD starting patients. Glucocorticoids secondary to use. Again, they don't really have any impact on lung function or mortality. They aren't used as monotherapy in COPD, unlike asthma. Again, it's a big difference between asthma and COPD, but they do decrease exacerbations and they can slow progression. And generally speaking, combination therapy has been shown to be helpful in large groups of patients, but there is that risk of pneumonia. Triple therapy, there's some evidence that patients do respond well to triple therapy. So there is that as well, why we're doing that in some patients. For refractory COPD, theophylline oral, we talked about that. And then roflumilast, which I just mentioned on their flowchart, is a phosphodiesterase 4 inhibitor. Phosphodiesterase enzyme, this is the first one I've talked about. There's a number of different ones. They do a lot of different things in the body, and this happens to be the number 4 one. And basically, it has effects on certain immune cells. By inhibiting it, it prevents an overreaction of the immune system via sort of a novel mechanism. It's expensive, but it has been shown to improve FEV1 scores and preventing exacerbations with little preventing exacerbations, but not necessarily having great quality of life effects, which if you're staying out of the hospital, that seems to be a good quality of life to me, but I don't know. What do I know? Lung reduction surgery and transplant would be the other final thing, which again, I'm not going to go into on that one. Not my cup of tea, but that's something that would be a possibility to look at for patients who are severely have severe COPD that we aren't able to treat with any of our other bag of tricks. Exacerbation is very similar to a asthma exacerbation. You use lower doses of steroids, but otherwise it's quite similar. A lot of times they'll use a antibiotic too, which we talked about during the antimicrobial lecture, kind of like a mini version of our community-acquired pneumonia treatment. And here's just talking about this. Very similar, again, supplemental oxygen, short-acting beta agonists, and then again, adding the antibiotics, that'd be the big thing. We don't treat asthma exacerbation with antibiotics. We do with COPD exacerbations generally. So that's it. That's the lecture of respiratory. Hopefully we can touch base at some point before the exam and do a review, but let me know about your questions, and I will have a quiz up shortly for this module.